When we talk about best practices in prescribing drug, what does that mean to you?
Best practices in prescribing drugs, to me, would be putting ourselves in the patient's shoes and selecting the best option for them. So there are other ways to look at that, and some of that is the objective data, guidelines. To me, it's always, since efficacy is very hard to differentiate it. That's one of the reasons the FDA, the industry actually, is unable to do head-to-head comparisons, because the FDA criteria to approve a drug is to show superiority. So it's very hard to show superiority on efficacy, but some of the ones that have been done comparatively show superiority on side effects and tolerability, which is very important because that's just in selecting a drug and doing a good patient practice or selection of drug, safety is super important. It's probably number one, assuming that all the medications work similarly regarding efficacy. Safety is number one, and tolerability is number two.
If someone develops a side effect when you put someone on medication, Trevor, for example, do you think about the mechanism of action of that drug informing your choice of next drug, or not?
Well, depending which drug, but yes, I do. I mean, I think a lot of the sodium channel drugs have that similar list of side effects, and if that patient has that side effect, I will, and has it at a medium to low dose, I will probably avoid another sodium channel drug in that patient. So a mechanism of action does play a role, but it's not, it's one variable that I look at.
Yeah, it's one, yeah. I think we all had the experience of having somebody on one sodium channel blocking drug, having it not work, switching to another sodium channel drug, and it works. Yes. Or the person who could not tolerate phenatone, for example, tolerated carbamazepine or tolerates lacosamide. And I guess it makes it a challenge. Now, you had also mentioned about single-day dosing. So are there certain things that you think about when you're prescribing a drug? Do you tend to lean towards drugs that can be given once per day? Is that a more important or a lesser important factor in your choice of medication?
Well, I think it's one factor. And I think from a compliance standpoint, we discussed that, and it's important from that standpoint. I think for some of the extended release formulations, the peak trough issue may be important for that patient. And in some patients, the extended release formulations also have less side effects because they don't have the same bimodal peak pattern. So in those patients who are on drugs that they're taking twice a day, some of them will say that an hour and a half after I take my drug, I feel drowsy and dizzy. Otherwise, I'm doing fine and I'm seizure-free. And that would be a good scenario to switch them to extended release formulation to obviate those two peaks.
Yes, I must say I've had that experience many times, and in theory, the extended release might be used once a day, but if the patient is comfortable taking it twice a day and it eliminates the side effects, I may be happy in that circumstance. There are a number of agents that are available with extended release formulations, I suppose. And does the half-life of the agent make a difference when you think about that, or not really?
It does for me, and I think this is a point that we may have differing opinions on. In a drug that is extended release but has a shorter half-life, I counsel patients extensively regarding avoiding missing medications, because if you're taking it once a day and miss that dose, your level of your drug will go down substantially. In contrast to a once-a-day drug like zonisamide or perampanel that has a long half-life, where if they, of course, I'll still counsel them not to miss their medications, but if they miss one dose because of those very extended half-lives, the level in their bloodstream is not going to substantially drop.
And Trevor, your comment in this regard relates to adherence, though, right?
That's correct. And I think the comment that Trevor made earlier in K2 is really important, because that makes me think about a population of patients not with focal epilepsy, but with generalized epilepsy, very common that we see in adolescents. and they fall into the category of being refractory because they're still having seizures. However, when they come, the only time they have seizures is because they miss their medication that even extended release has a short half-life. So that's when this selection of longer half-lives may be a little more forgiving for those patients. So clearly, if they take it all the time, that may not make a difference, but the human factor is hard to take it away.
And there was some data, there was a paper published a while back by Ed Fott, I think.
That's correct.
About that. And what did that show?
So one of the things is that one of the dumbest questions I ever asked for about a decade was, how often you miss your medication?
Never.
And people say never because it's hard to report something you forgot. If you knew it, you would have taken it. But really, when you ask people that, it's like, how do you know? And if they have a diary that they mark their dosing, or they have at least counting the day that they refill the medication, they'll know if they're missing and how much they're missing. So Ed Fott looked at the possession ratios, how often you don't have the medication in your hands from the Medicare pharmacy registry. So when you have medications that we prescribe number 30 once a day, is refilled every 33 days, which means 10% is not taken. When you have number 60, BID, it lasts 36 days, 20%. When you have 90 number TID, it lasts like 42 days, it's like 37%. I can attest for the QID, I'm allergic to penicillin. And when I took erythromycin, my 10-day supply always lasted like 50 days. No, it lasted like clearly instead of 10 days, like 16, because the compliance goes down to 54% on adherence. So clearly the once-a-day options are much better. The future would be to have injectables like we have in other areas of medicine, or pumps that take care of the human factor.